May I now call upon Dr. Pratima Radhakrishnan?
To squeeze in complicated monochorionic twin pregnancies in 10 minutes is a Herculean task, but I will try my best. So monochorionic twin pregnancy surveillance starts from 11 weeks, because from 11 weeks we can start seeing discordance in amniotic fluid, in growth, we can see discordance in congenital anomalies, and of course 30% of these monochorionic twins will develop some sort of complication during pregnancy. So very early from the point of diagnosis till the time that they are managed and treated and delivered has to be looked after very well. So one of the most important complications of monochorionic twin pregnancy is twin-to-twin transfusion syndrome. Sorry, we went back. Twin-to-twin transfusion syndrome, which basically means that there is a discordancy in the amniotic fluid, and this is primarily because there is vascular anastomosis on the placenta which is unbalanced, and therefore there is hypovolemia in one baby which causes oliguria in that baby, and therefore there is less amniotic fluid, and this sets off the vasopressin renin cascade system. There is an increased vasopressin, and there is a sort of a renal dysfunction. On the other hand, the recipient baby, which because there is more blood flowing into the heart, there is a cardiac stretch, and because of the cardiac stretch, there is a release of the atrionatriuretic and BNP proteins, which causes further polyuria and polyhydramnios, and this cascade keeps going round and round and causes a kind of a vicious cycle there. And again, because of the cardiac overload, we have hypertension because of increased flow across the right side of the heart. So there's tricuspid regurgitation and hypertension in the recipient as well. However, the good news is this entire thing, because it is a physiological problem and it is a problem in the placenta, so if you treat the placenta, this actually revert completely back to normal, and this we have seen in our babies as well. So most of the times the referral is something like this. It's a Momo twins with polyhydramnios. And most of the time they are not. It cannot be. It is unless it's proved otherwise, it is monochorionic diamniotic twin pregnancy with severe TTTS, because the cord, as you can see, is stuck onto this baby, and the membrane is stuck to this baby. And the fact that the cord is so close to the baby and doesn't fall off the baby is a very clear indicator on the ultrasound to say that it is a stuck twin and it is not a Momo twin. So you have to look very, very carefully. So this requires a certain level of expertise, of course. Now, that is actually the stuck twin. Now, the twin-twin transfusion surveillance is performed according to the Quintero staging, and Quintero staging is not of any prognostic value. It's primarily for communication, and basically we monitor the from 16 weeks every 1 to 2 weeks, and we call it stage 1 if the donor bladder is still visible, donor 2 if it is absent and Doppler is normal, stage 3 when the Doppler becomes abnormal, stage 4 hydrops, and stage 5 one baby is already dead. But there are a lot of limitations to the Quintero staging in that it does not follow. So basically, if there is a pregnancy in stage 1, it doesn't mean that next it will be stage 2, or it can go from stage 1 to stage 3. Sometimes you can even have stage 1 with cardiac changes. And therefore, a further modification has come to include the cardiac changes, and of course I'm not going to go through that. There are 3 different types. Basically what I'm trying to say is there is cardiac dysfunction in these babies, and before the cardiac dysfunction becomes irreversible, even in stage 1 sometimes we have to treat them with laser. So in stage 1 there is discrepant amniotic fluid, and pretty much is very obvious diagnosis on the ultrasound scan, and TTTS is a discrepancy in the amniotic fluid. The size can be the same because acute TTTS, both the babies can be of the similar size, right? So one has to be very clear about the diagnosis, because TTTS, the treatment, there is only one treatment for TTTS, and that is fetoscopic laser. And people have tried amniotic reduction, amnioreduction, etc., but it is not performed routinely anymore because of the evidence that clearly is in favor of a fetoscopic laser ablation. Now, the choice of approach, of course, it would be that if there is any Quintero stage with any cardiac changes in the recipient, then you would go for. If there are maternal signs and symptoms like a shortening cervix and maternal discomfort from symptomatic mother because she's getting hyperventilation and she's getting reduced lung volume problems and breathing difficulties, then you would go in for a laser. Gestational age, of course, because generally we prefer not to do it after 28 weeks. So the best time to treat them is between 16 to 28 weeks, and of course the availability is there now. So stage 2, 3, 4, definitely there is enough evidence there for endoscopic fetal laser surgery, and with that there is increase in double survivors, there is increase in even single survivors, and of course the earlier we do that, at the right time we do that, when the cervix is reasonably of good and before the irreversible changes happen, the better is the outcomes. And it has clearly reduced double IUDs and increased the gestational age at delivery, and as we know, preterm labor is one of the biggest problems that we face in twin pregnancy as well. Now, what happens if one baby dies after laser? Because there is a possibility that one baby can die after laser. In these cases, the risk of neurological problem becomes less than 2%. Unlike pre-laser, the risk is more than 25% of neurological problem. So because post-laser, this pregnancy starts behaving to a large extent like a dichorionic twin pregnancy, because that is the aim of laser, is to actually laser all the anastomosis, so you separate the circulation, so one baby is not dependent on the other. So immediate delivery, definitely not immediate delivery. You would manage, you would continue the pregnancy, you would do MCA Doppler to check for anemia, because anemia is one of the risks of the survivor, but we can give a blood transfusion and make it better as well. There is a role for MRI at 32 weeks in these pregnancies, and we would deliver them as per Singleton norms, that is obstetric indications. We perform this laser under spinal and or local anesthesia in the operating theater, and the most important factor for obstetricians primarily is to refer them early, because early referral will actually give much better outcomes, and that is the main way to optimize the outcomes for these pregnancies now. Even post FLA, there is certain things that need to be done to follow up these pregnancies, because procedures are always successful. Procedures don't go wrong. It's extremely rare for a procedure to go wrong. However, the outcome of the pregnancy largely depends upon what kind of placentation was there even before we did the procedure, and at what time we have done the procedure as well, because the early and at the right time we do the procedure, the outcomes are definitely much better as well. So what are the other challenges that we face? Cervical length is a big challenge we face, because the shorter the cervix, the more likely they will end up with early preterm labor or even miscarriage post procedure. And of course there is a role for cervical cerclage, but we prefer the cervical cerclage after the laser, because you can do an amnio drainage and then do the cervical cerclage, and many times you may not even require to put a cerclage, because the cervix goes back to its original length. Because the main problem in these pregnancies is over distension of the uterus, which causes shortening of the cervix. So once you treat the over distension post laser by doing an amnio reduction, the cervix actually starts getting better as well, and of course progesterone might help. There's no clear-cut indications, but it would help to some extent. And of course one of the biggest challenges is very poor recognition of even monochorionicity, because even twins are reported as twins. They should not be reported as twins. Chorionicity should be determined in the first trimester, and then onwards close follow-up must be done. So early recognition, timely referral is very important. So what are the other complications? Selective FGR, where one baby is small, one baby is normal size, and the discordancy should be more than 25% to call it a selective fetal growth restriction. And typically it is a small baby with a normal size baby, right? And also amniotic fluid is oligonormal. In TTTS we had oligopoly. Here it is oligonormal. And it could be late onset, it could be early onset. I'm not going to go into the details, but early onset will actually have a worse outcome. And the early onset is further divided depending upon the Doppler. If you have a normal umbilical artery Doppler, it's type 1, which is really good prognosis. Type 2, where you have absent or reversed end-diastolic flow, and this requires laser now. In fact, I'm just coming back from the Fetal Medicine World Congress, where it was discussed widely, and because of the poor prognosis for this group, here is again a position where we would do a fetoscopic laser, and type 3 is where you can have intermittently. Okay, I will rush through my last few slides. TAPS is where one baby is anemic, one baby is polycythemic, and it can, again, the monitoring is by the MCA Doppler, as we have already seen. Treatment is blood transfusion of the anemic fetus, and if there is a recurrence of you require more than 2 intrauterine transfusion, then you may have to re-laser these pregnancies. Bipolar cord coagulation is not at all our favorite, because here you have to sacrifice one baby to save the other baby, and it's been a very long time since I've done a bipolar cord coagulation, because by doing a laser, fetoscopic laser, you give the other baby a good chance to survive as well. So unless there is discordant anomaly or severe growth restriction, the prognosis is going to be extremely bad. We would prefer not to do that. Right, and TRAP, I'm not going to talk about TRAP again. TRAP is primarily intrafetal laser before 16 weeks, early diagnosis, early treatment. Monochorionic monoamniotic twin pregnancies, definitely there is a role for continuing this pregnancy. Cord entanglement is always present. We don't need to be worried about it. It's present even at 12, 13 weeks. And after 28, 30 weeks, the complications from cord entanglement becomes less, simply because the movement of the babies become less. And they tend to have a good prognosis. They prefer to deliver by 32 to 34 weeks. So how do we optimize? The only way we can optimize is by following a set protocol. And the protocol is there up in the BSOG guidelines, very clear-cut guidelines that once the 11 to 14 weeks you have dated the pregnancy, you have labeled the chorionicity, you have checked for chromosomal and structural abnormalities. For 16 to 8, for monochorionic twin pregnancy, from 16 weeks onwards, every 2 weeks they have to be monitored. There is no other way to monitor these pregnancies. Every 2 weeks, from 16 weeks, if there is discordancy, it's every week. That's it. So, and there is clear-cut guidelines. So ways to optimize: early diagnosis at 11 to 14 weeks, early referral so that we can standardized care for these pregnancies, and early treatment is how we can optimize outcomes. There is a Facebook community where parents can go and discuss and talk about their problems. I would encourage even doctors to go there and listen to what the parents have to say about it, because there's one way for us to learn is actually from our parents as well. And thank you very much.